Now I invite Dr. Ganesh Raman to speak on MIGS mix in primary angle closure disease.
Thank you, Dr. Meena, and thank KSOS for providing me this opportunity. I'm going to speak to you on MIGS in primary angle closure disease. So MIGS, if you look at the advantages, there are numerous. You have spare the conjunctiva, it's ab in tono, sparing the sclera also, because ultimately if to do glaucoma surgery, you need significant amount of sclera. And then reduce surgical time. And the only demerits, some of them are that you cannot lower the IOP as good as TRAB. And of course, some of the MIGS do involve the conjunctiva. And then it again precludes other modalities of treatment. So issues with MIGS and angle closure is actually MIGS are actually indicated for open angle glaucoma. So if you are using it for angle closure, it's off-label use. If you use any device, for example, let's say iStent or a KDB, it's off-label by the manufacturer or the innovator or the developer. And then insurance also plays truants in that, so you don't get insurance approval for MIGS in angle closure. So if you write a diagnosis of PSEG and then MIGS, it comes boomerangs back on you. You don't get a sanction, okay? And most of the patients have to pay out of pocket. So MIGS, which are device-based like KDB, iStent, Hydras, they're quite expensive. So what we are left with in the Indian scenario is GAT, Tanito, and BANG. So this is some of our data. So the problem with MIGS again is that it's sometimes so good that patients don't come back to you. So look at the last column, and the post-operative IOP at 6 months is pretty good. So you have the last column is some of the patients haven't come back, but you still have good IOP at 3 months, 15, 16, 19, 16, 12, like that. So you get a good intraocular pressure reduction, and these are all off medications with very good visual acuity. And the diagnosis is all PSC or PSEG, and look at the cupping. So you have some of them 0.4, but many of them are 0.7 and above. So advanced, moderately advanced glaucoma. I'll come to this case. So this patient has bilateral angle closure glaucoma, 0.7 cupping, 0.5 cupping in the right and left eye. Presenting pressures were 36 on 3 to 4 medications, rheumatoid arthritis and SLE, and she has undergone multiple LPIs, and we couldn't do anything much for her in terms of TRAB, so we thought of MIGS. So finally what we did was, this is how she presented, past history of scleritis and healed now. So we went in and did all these are the options which were present to us, but we finally did a GAT with phaco for her. So having done that, we had very good response at 1 month, so immediately we did the other eye as well. So both the eyes underwent phaco GAT. And this is how she presented at 1 month follow-up. And the intraocular pressure was 15 millimeters in the right eye, 13 millimeters in the left eye. This is at the end of almost 6 months. And the angles widely opened up. Even before that, the angles were pretty much opened up. So she was on 3 to 4 medication, but then we still went ahead and did a glaucoma MIGS procedure for her, because we knew she's going to likely to progress. There's no assurance that she will not. And the main advantage was we were able to stop all the medications. So that's one saving grace in her situation. So conventionally, we usually address the nasal angle in MIGS. If you take any MIGS, for example, KDB or any MIGS, we address iStent. Nasal angle also has more extensive collector channels. Whereas in this particular patient, we did an extensive GAT, that is an excisional goniotomy. We excised all the tissue, or ripped open all the tissue, because we were able to access the temporal region, and helps to recruit temporal collector channels for aqueous humor, percolation, outflow. So if you were to do something like MIGS in angle closure disease, I would strongly recommend something like a GAT or a Tanito, which addresses both the nasal angle as well as the temporal angle for better percolation. So this is something which we have to think of. But any device-based procedure, you have to think of because they are expensive, you have to think of the insurance part, and they are not labeled applications for that. So coming to Tanito's microhood, so this is a device which addresses it has three devices actually. So in A, you have the straight shaft. So it cuts the nasal angle about 2 clock hours superiorly and 2 clock hours inferiorly in the right and left eye. This is how it's represented. And then you have the angle device. So the angle device, you approach supranasally on the right eye and the left eye. And one device which is right-handed will cut 2 clock hours to the temporal region, and the left will cut 2 clock hours to the infratemporal region. So what essentially you do is you have 120 degrees of cut here, and then you have 120 degrees of cut here. So instead of a 120 degree alone, you are able to open up the trabecular meshwork up to 240 degrees. 120 plus 120 makes it 240, so it's close to. So the only region which you leave out is, for example, if the right eye, this region, and the intronasal region. So you leave out about 120 degrees, but you open up most of the trabecular meshwork. So this is again a very cost-effective device. It's shortly going to be made available, and this is something which you could think of. So this is how the procedure works. This is the video courtesy of my friend and colleague Devendra Maheshwari. So after the phaco emulsification, and of course, you should know intraoperative gonioscopy for this. So this is being approached from the temporal side to the nasal aspect. And then this this is the supranasal part. This is the supranasal part being approached infratemporally. So this is the angled device. Sorry. So you can see the trabecular meshwork. You can see that the iris has fallen back. If you have synechia, you could always do a mild goniosynechial lysis and then see the trabecular meshwork. And once you incise, the trabecular meshwork gets excised, and you see the outer wall of the Schlemm's canal. If you have induced hypotony, you will have some bleeding from there. So it's always important that you do the lower part first and then you do the upper part. And this is the other device, which is the pair of that, and you incise the supratemporal part. So this is being approached from the again the procedure is being done. So if you don't have a good view, you can always reinflate the chamber and then proceed with it. So if you cut it in size correctly and you have induced hypotony, you will have a little bit of blood coming out from the trabecular meshwork. I don't know whether you have seen the... Yeah, so this is, I think this is being approached. No, this is also, yeah, this is again the same, just the straight incision one. So what you saw there was the angled one. This is from the temporal approach, so you address the nasal area. And of course, as you can see from the video, you can do it topically as well. So this is a straight angle device. And I think it's the same thing. I'll go to the next slide here. And certain complications you should always be aware of. This is of course a canaloplasty, but you must know that a GAT and such procedures not very easy in angle closure conditions, mainly because can I have the video please? Is it playing? No? Okay, that's okay. So case selection is very important. So preferably always do a PI first because as I already mentioned, risk of malignant glaucoma is quite high, and the EAGLE study can definitely be misleading. So don't go by that and treat your patients with just cataract alone. Mild to moderate glaucomas is where it is actually indicated. Advanced glaucomas, they don't respond so well. Do goniosynechial lysis if you find that there is extensive PAS. And it's very important to perform uneventful cataract surgery. So if you have vitreous in the AC or the lens is not placed in position properly, it's very, very difficult to do the procedure after that. So avoid excessive iris manipulation. You will have extensive pigment dispersion, which will go again and block the outer wall of the Schlemm's canal, and your collector channels will not percolate so well. Always deepen the chamber with sodium hyaluronate. and flatten the iris against the PCIOL in the back. So anybody who has done MIGS, you'll notice that the blood doesn't just come from the angle, it comes from behind the iris as well. Because as you introduce the suture or the incise the trabecular muscle, you are inducing shearing stress. The stress gets transmitted to the ciliary processes at the back and they tend to bleed. It's also the iris root as well as blood from behind the iris. If you are doing a GAT procedure, leave sodium hyalurate 40% fill and anterior chamber. That's what we do regularly. But if you are doing a limited procedure like KDB, bang, Tanitos, we don't leave any OVD device in the anterior chamber. Be very careful of patients on anticoagulants or hypertension patients who are not under control, and be very careful of fluctuating BP. They may have taken tablets just before the visit. Once they go back, they'll stop the tablets, the BP will fluctuate, they'll report back with high FEMA. And then you'll end up washing them in the in the OR again. We use very less steroid for our patients once we are done MIGS, whether it's any type of MIGS, whether it's iStent or angle closure, we do GAT, KDB. We use only steroids only for 10 days. Rest of the month it's 3 times a day NSAIDs, preferably we use Nepafenac, and antibiotics 4 times a day, 15 days. And pilocarpine 2% for 10 days, 3 times a day. And if the intraocular pressure fluctuates, we repeat pilocarpine for 10 more days. And that's just about settles it, because as you've seen the data which I showed you, KDB at the end of 3 months, they do pretty well. And we see them at 15 days, 45 days, and 3 months. So you could have some complications, especially in the early curve. You could have a cyclodialysis cleft. You can strip the DM. You can have hyphema, which requires AC wash, raised IOP. And you could always have blood behind the IOL, and then which will require early YAC capsulotomy. So ideal MIGS are patients who have MD of less than 15. And this is just an example to show you that a patient had blood behind the IOL, and then we had to do a early YAC capsulotomy within about 3 weeks' time. So I'll stop here. Thank you for a patient listening.